We find ourselves in Abiquiu, New Mexico, nestled between the red rocks and the blue sky at the home of the famed painter Atlanta O'Keen, famous for her beautiful landscapes awash with pink and turquoise. But if I heard correctly, she's on to a different period in her paintings, the Vermilion period. So I guess that makes it as good a time as any to talk about third trimester bleeding, which is also called antepartum hemorrhage. This typically refers to bleeding that occurs after 20 weeks gestational age. As you may remember from our vaginal bleeding in early pregnancy DDX, vaginal bleeding before 20 weeks gestational age is typically due to early pregnancy loss or ectopic pregnancies. As you'll see in this sketch, third trimester vaginal bleeding has its own different laundry list of causes. We're going to go over the patient presentations of all the different causes of third trimester bleeding, highlighting the things that distinguish one from the others. The chief complaint is going to be vaginal bleeding after 20 weeks gestational age, roughly in the third trimester. Third trimester bleeding is going to be symbolized with this tube of vermilion number 3. Now we're going to divide our differential into obstetric versus non-obstetric causes of vaginal bleeding, and then within obstetric causes, into painless and painful vaginal bleeding. Pain may manifest as painful contractions, abdominal pain, or lower back pain. The causes of painful vaginal bleeding are going to be underneath this dark, angry-looking painting with big pain lines. All of the causes of painless vaginal bleeding are going to be in front of this window looking out at the beautiful and serene New Mexican scenery. There are 2 obstetric causes of third trimester painless vaginal bleeding: placenta previa and vasa previa. Let's start with placenta previa, represented by this placenta cushion covering this uterus stool. As you may remember from our abnormal placentation sketch, placenta previa is when the placenta completely covers the internal cervical os. The majority of these patients will present with bleeding at some point during their pregnancy, usually during the third trimester. These patients will present with painless vaginal bleeding and or postcoital bleeding. Risk factors for placenta previa include a history of placenta previa, a history of C-section, represented by this art history book falling out of an unzipped uterus bag, and multifetal gestations, represented by the multiple paintbrushes also in the uterus bag. An ultrasound is going to be your main diagnostic tool here, which is why these sonar lines from the gramophone are wafting over the previa cushion. If you see the placenta overlying the cervix on ultrasound, then you've diagnosed a placenta previa. The other cause of third trimester painless vaginal bleeding is vasa previa, symbolized by these red and blue flower stems running over the top of the uterus vase. A vasa previa is when there's a velamentous cord insertion that runs over the internal cervical os. A velamentous cord insertion means that a stretch of the umbilical vessels run through the amniotic membranes, which means they're very poorly protected and prone to tearing open. This is why, when compared to a placenta previa, a bleeding vasa previa is much more dangerous. A tear in the cord can cause catastrophic blood loss straight from the fetus. We'll remind you of this high-risk situation with a big puddle of red paint underneath the vasa previa vase. Vasa previa is more common in multifetal gestations, again symbolized by these multiple paintbrushes, IVF pregnancies, represented by this test tube vase, and pregnancies with a succenturiate or extraplacental lobe. Vasa previas are usually found because the patient will have an episode of vaginal bleeding and no placenta previa will be seen on ultrasound. On a fetal heart tracing, you may see a sinusoidal pattern, just like is on this vase, due to the fetal anemia a ruptured vasa previa can cause. If there's a high suspicion for vasa previa, this is an obstetric emergency and delivery should happen immediately via emergent C-section. For more about the details of treatment for placenta and vasa previa, head on over to our abnormal placentation video. Spoiler alert, you gotta do a C-section. Now let's move on over to our angry painting and into the causes of painful third trimester vaginal bleeding. The main culprit in this category is placental abruption, represented by this flower abrupting out of the uterus plantar. Placental abruption, or abruptio placentae, is when the placenta prematurely shears off the uterine wall, which causes bleeding that ranges from mild to catastrophic hemorrhage. The exact cause of abruption isn't known, but there are many known risk factors for it, which we'll go over in a minute. Placental abruption usually presents with painful bleeding, and usually uterine contractions are present. It's worth noting that it's also possible to have placental abruption without vaginal bleeding. I know, crazy, right? This is called a concealed abruption and happens when the placenta shears off the uterine wall, but there's no passage to the os, so the blood stays concealed between the placenta and the uterus. Besides massive hemorrhage, other risks of placental abruption include maternal DIC due to a consumptive coagulopathy, which will represent with this dice pattern, hypovolemic shock, and even fetal death. Placental abruption is a clinical diagnosis. You need to have signs of blood loss plus risk factors for abruption. That's why it's super important to know the risk factors for placental abruption. So let's go over them now. The biggest risk factor for placental abruption is hypertension, which will represent with this tea kettle emitting high pressure steam. So it makes sense that hypertensive diseases put a patient at risk for abruption. This is true either with regular hypertension or a disease on the preeclampsia spectrum, represented by the clamp spout on the tea kettle. Cocaine use, represented by this hot cocoa box next to the high-pressure kettle, also raises blood pressures. Other risk factors include smoking and abdominal trauma, often due to motor vehicle collisions. We've represented these with a cigarette in an ashtray as well as a broken mug with a car on it. Another risk factor for abruption includes a rapid change in uterine size. This can happen with rupture of membranes in someone who had polyhydramnios or after delivery of the first twin in a multifetal gestation. On physical exam, the uterus can feel firm, which is why this plantar has a hard stone texture to it. It may also be tender to palpation. If the abruption is massive enough, the blood can enter the myometrium and extend to the uterine serosa. If this happens, during the C-section, the uterus may look purplish blue, which is called a cuvulaire uterus. In terms of what you'll see on fetal heart tracing, this also depends on the extent of the abruption. If it's large enough of an abruption, you may see features of a non-reassuring fetal heart tracing, such as recurrent decelerations, absent variability, or fetal bradycardia. On the maternal tachometer, it's also possible to see frequent contractions. This is because bleeding irritates the uterus and causes it to contract, which causes more bleeding and then more irritation, so you can get a lot of contractions. On labs, if the patient is undergoing DIC, you'll see a low fibrinogen. The cutoff can be dependent upon the lab, but it's usually less than or equal to 200 milligrams per deciliter. If you see this, you're going to want to start transfusing blood products. As for other studies, ultrasound isn't super helpful in helping you recognize an abruption. This is because the blood clot can look the same as the placenta on ultrasound, though sometimes it's possible to see a retroplacental hematoma. What's more common is observing a big blood clot that's adherent to the placenta, which you can see after the placenta has delivered. This is evidence that would support your suspicion of an abruption. The treatment for placental abruption depends on the degree of bleeding, the clinical status of mom and the fetus, and how far along the pregnancy is. If there's a massive amount of bleeding, mom is showing signs of hemodynamic instability, or the fetus is showing signs of distress on the fetal heart rate monitor, such as absent variability or terminal bradycardia, you must deliver the fetus. Just like Atlanta O'Keen's assistant is helping to deliver this flower out of the vase. Otherwise, the decision of when to deliver depends on many factors, which can be a multidisciplinary decision that's beyond the scope of this sketch. Another cause of painful obstetric bleeding can be physiological labor itself, and the pain would be coming from the patient's contractions. Often, because the cervix is very vascular during pregnancy, as it begins to soften and dilate, it can bleed. This is sometimes called bloody show. Compared to an abruption, this bleeding is much less in quantity, and may be darker in color because it isn't fresh blood. To remind you of this, we've drawn in this darker red paint dripping on an invitation to an art show, which should help you think of bloody show. You would suspect normal labor and cervical dilation as the cause of vaginal bleeding if the patient had no risk factors for placental abruption, her vitals are stable, and the fetal heart tracing was reassuring. If the patient is term and in labor, let her keep on going. She's going to have a baby soon. If she's preterm, it depends on how far along she is whether or not you're going to want to try to intervene. But that's a topic for another sketch. As for non-obstetric causes of third trimester bleeding, these are mostly structural. There may be a labial, vaginal, or cervical laceration, represented by this lacerated canvas, that's causing the bleeding. So make sure to do a thorough speculum exam to evaluate for any lacerations and if there's active bleeding. Bleeding may also come from a friable cervix, represented by this crumbling canvas. As you may remember from our cervicitis and PID sketch, cervicitis is due to inflammation or infection of the cervix. This type of bleeding is more likely to present as spotting with no signs or symptoms of a larger amount of blood loss. If you see a friable cervix on exam, you should evaluate for infection with a gnat for gonorrhea and chlamydia. For more information about the full workup for cervicitis, head on over to that sketch. Finally, malignancy of the lower genital tract can also present as bleeding. We're representing malignancy with our recurring symbol, a crab. Unfortunately, pregnancy is a time that malignancies can be discovered. So if you see any suspicious lesions on your pelvic exam, such as fungating masses, make sure to alert gynecology oncology, obtain any necessary imaging, and take a biopsy if it's in a safe location given that the patient is pregnant. As in, don't go removing a large chunk of the cervix. Now that we've gone over the causes of antepartum bleeding, let's go through a typical workup that you'll want to do when one of these patients presents. And for that, we're going to go to the artist herself, Atlanta O'Keen. The first thing you're going to want to do is assess for the amount and briskness of bleeding, just like the famous Atlanta O'Keen is assessing the red paint on this canvas. You should also assess the patient for hemodynamic stability. Specifically, look at her heart rate and blood pressure and note if she's tachycardic and/or hypotensive. In terms of labs, as a part of your standard workup, you should get a CBC to establish a baseline hemoglobin and platelets. You can also trend CBCs to get a sense of whether ongoing bleeding is occurring. In addition to obtaining and trending a CBC, you should also obtain and trend coagulation studies, which include a PT, PTT, INR, and fibrinogen. We'll remind you to get these important labs with these little fibers sticking out of the adobe wall. As we mentioned earlier, a fibrinogen of less than or equal to 200 milligrams per deciliter usually means you have a case of DIC on your hands, which is an emergency. Abnormalities in the other coagulation studies should also serve as big red flags that there's been a clinically significant blood loss. If a patient presents with vaginal bleeding after 20 weeks gestational age, do not perform a digital cervical exam until you've done an ultrasound to rule out placenta previa. That's why we've made this gramophone an analog one, as in not digital. Get it? Finally, the last thing you must do once a patient presents with antepartum bleeding is put her fetus on the fetal heart rate monitor to assess for fetal well-being. The main question that's going to come up is, should I deliver the baby or not? This is a complicated question, one that often involves a multidisciplinary team if the situation calls for it. So we're just going to go over the easier stuff. When you definitely should deliver the baby and when it's safe to wait. As a rule of thumb, if mom is unstable, stabilize her first before the fetus. As with any situation in medicine, start with your ABCs: airway, breathing, and circulation. If there's been a lot of bleeding or you anticipate more bleeding, place 2 large bore IVs and start fluid resuscitation with IV fluids if you anticipate further bleeding. It's also a good idea to notify the blood bank that the patient is in-house and to go as far as to type and cross a number of blood products that match your patient's blood type should you need to transfuse in the future. If the bleeding is severe, you should also start monitoring urine output, which is a good objective marker of maternal perfusion. We've represented it here with this container of yellow linseed oil. At minimum, an adequate urine output is 0.5 milliliters per kilogram per hour, so this linseed oil container holds 0.5 mLs. If there's mild bleeding that stopped, a reassuring fetal heart tracing, no signs of coagulopathy, and no anticipated future bleeding, it's okay to wait and manage expectantly, especially if the fetus is premature. If mom is stable and the fetus is showing signs of distress, such as a non-reassuring fetal heart tracing, deliver. If you're anticipating a preterm delivery, administer betamethasone if the fetus is less than 37 weeks gestational age, and magnesium sulfate for fetal neuroprotection if the fetus is less than 32 weeks gestational age. Antenatal corticosteroids and magnesium sulfate are represented by this moon on a magazine cover, respectively. And finally, if the patient is Rh negative, administer RhoGAM to prevent alloimmunization, as there could have been mixing of fetal and maternal blood, especially if there was an abruption. Okay, just a quick review this time so we can let Miss Keen get back to work. We went over the causes of third trimester bleeding during pregnancy and then divided up the causes into obstetric versus non-obstetric. Then we further divided up obstetric causes into painful versus painless vaginal bleeding. Causes of pain less vaginal bleeding include placenta previa and vasa previa. Causes of painful bleeding are placental abruption and normal labor with bloody show. Some non-obstetric causes of bleeding are lacerations, cervicitis, and malignancy. In terms of the workup, you'll immediately assess for the amount of bleeding and for whether or not the patient is hemodynamically stable. For labs, you should get a CBC and coagulation studies to assess for signs of anemia and for coagulopathies, including DIC. Whatever the cause of bleeding, always stabilize mom first. If mom and fetus look stable, in general, it's okay to wait and watch. If mom is stabilized and the fetus is showing signs of fetal distress, you should deliver the baby. And with that, we leave the vermilion period behind. Hopefully Atlanta O'Keen's next set of paintings don't remind us of so much blood. Hey Atlanta, how about a little blue paint next time? Oh no, she didn't seem to like that suggestion. Gotta run. See you next time.